Thank you very much for the invitation. It's a great pleasure to be here. Really enjoyed Athens. So let's see if I can get this one in here. Okay. So I'm going to talk about research we have done for 25, close to 30 years to try to find out new type of treatments for Achilles tendinopathy. Let's start with the comes that order. Sorry, with the Achilles mid portion. So when we started in the 90s, all these patients were treated with anti-inflammatory medication because everyone believed it was an inflammation, and the results of conservative management was not very good. So we decided to first try to find out, is there really an inflammation in the tendon? So what we used was microdialysis. We put small tubes into the mid portion of the Achilles, 4 centimeter long small catheters in tendons with tendinopathy, painful thickening here in the mid portion, and also in normal tendons, controls. And we analyzed during resting. I can lift it out. It's better. Oops. So we analyzed during resting conditions for 4 hours. And what we found was that there were actually normal prostaglandin levels. So there were no signs of a prostaglandin-mediated inflammation inside the Achilles. There might be one outside, but I think the Danish group have shown later on that there was no inflammation outside either. We found high lactate levels, so there can very well be ischemia in the tendon. However, now this is done when they already have started to have pain, so we don't know if ischemia is the first that happens. But when they have this painful nodule in the tendon, then they for sure have ischemia in the tendon. And we also found high glutamate levels. And glutamate is a very potent pain modulator in the central nervous system. So this was actually the first time this was found outside the central nervous system. So to double check if there anyhow wasn't an inflammation inside the tendon, we also took lots of biopsies, and we did gene analysis. We looked at a couple of thousand different genes, and we found no upregulation of pro-inflammatory cytokines. So that was sort of the final proof that there is no inflammation inside the tendon. So at about the same time, we did this, test with the eccentric training I told you about previously, that we tried painful eccentric loading on patients having mid-portion tendinopathy. And with the findings of good result on myself, we started to apply this method to the patients on the waiting list. So I had around 20-25 patients waiting for surgery, the old method surgery, and all of them they first wanted to try this eccentric loading, and very interestingly, all 15, there were 15 included in the study, all 15 were so good after this treatment that they didn't want to have any operation. 1 year later, one patient came back and was operated. So that was another research finding, that you could do opposite what was meant to be done. At that time in the 90s, tendons were going to be treated below pain. There should be no pain during the rehab, and we did opposite. We allowed pain, and as much pain as tolerated. So that was a research finding showing that you can do that and you can have a good result after doing that. Interesting, if you look at the tendons before eccentric training, they look like this. And if you follow them up over time, they look better and better. So when they did eccentric training, the tendon started to remodel and became more normal in its shape. We can of course not say that this is a completely normal tendon, but we can at least say it's thinner. There is no pain, it's thinner, and it looks more normal than it did before we started. So that was another research finding. We also found that, at that time I didn't do ultrasound myself. We sent all these patients to a colleague at the radiology department, and he had a new equipment where you also could use Doppler to look at the tendon. So he called me and he said, it's very interesting because all tendons you send me, they also have a very high blood flow inside the thickening of the tendon. But that is something we don't see in the normal tendons. So that was a new finding, that there was high blood flow when they had this pain in the thick tendon, but not in the normal tendon. That started thinking about the importance of this blood flow. Is it important? From what side does it enter the tendon? Well, it enters the tendon from the deep side, the resting side of the tendon. So we started to take biopsies. So we took biopsies in local anesthesia, biopsy tendon and fat outside. We took lots of biopsies, as you see, more than 300. And it was possible to do that also in normal tendons without causing any problems for the patients. So ethically, it was not a problem to take those biopsies. But of course, you have to be careful. Follow them closely afterwards. So interestingly, what we found, oops, that was a little quick. What we found was that there were no nerves inside the tendon, the Achilles, but lots of nerves outside, and those nerves were located in very close relation to blood vessels. Showing on this picture here, you see this is the tendon, blood vessel, and nerves. So these nerves were found outside and not inside the tendon. And if you looked at studied what kind of nerves it was more or less mainly sympathetic nerves. There were also sensory nerves, but lots of sympathetic nerves. And as you know, sympathetic nerves have many different functions. It can also cause pain, be related to pain, and it regulates blood flow in blood vessels and many different functions. So with that finding that the nerves were located outside the tendon, we started to, with ultrasound guidance, inject local anesthesia just outside the tendon, only where we had this high blood flow. And by doing that, small volumes, 1-2 milliliters, the patients were completely pain-free. So that was interesting. I had been for many years operated these tendons by cutting out big slices of the inside because we thought the pain was from the inside, and after those operations they needed to be in a cast and they were away for about 6 months. And now we found that there is actually no need to go inside the tendon because the pain is outside. So that you will hear more about later on in the afternoon, how we use that finding. The radiologist I told you about, the one we sent all the patients to, he became interested in research. He was then close to 60 years old, but he asked if he could do research on this. So he was one of my research students. And he did a really good thesis where he was focusing on the outside of the tendon, where the nerves and vessels were, and with an injection he was trying to cure the pain. And then we looked for different substances. It should be safe substances to use. So we found polydocanol. As you know, polydocanol is used to treat varicose veins. You inject it into the vein, and the vein gets fibrosed and disappear. So we used this medication. and it's also good because it was originally produced as a local anesthetic. So you immediately get a response whether the patient is pain-free or not. So he was injected small volumes with the lowest concentration, 5 or 10 milligram per milliliter. Very small volumes, because if you inject too much of this polydocanol around the tendon here, then you destroy all the blood flow. And that's not good, as you know. So very small volumes in this area here outside the tendon. And by doing that, he could relieve the pain. It required a couple of injections, but he could relieve the pain. And following these tendons over time, you see 6 months, it looks much better compared to here. And 2 years, it looks much, much better than here. So interference outside the tendon here on this side improved the inside of the tendon. So there was nothing done inside the tendon, everything was done outside the tendon. So that was actually a method, a treatment method that we started to use, but there were limitations. It was quite difficult to use this procedure. You had to be skilled with the ultrasound guided procedures, you know, and you had to stay with small volumes. So it was difficult for other groups to reproduce the result. Also, you needed 3 arms. One arm to put the probe on the tendon, another arm to put the needle in position, and a third hand to help to push in the volume. In Norway they reproduced the results, but in other groups they had quite poor results. In Holland they had very poor results, but we know that doctor, he used up to 10 milliliters. He flushed the whole tendon to get rid of the high blood flow, and got lots of problems with poor blood supply surrounding the tendon. So if you're using that method, you have to be very careful with the way you inject and how much volume you use. So then an interesting thing happened. There was an English track and field runner, a very high level runner, had won silver medals in sprint, and he was sent to us for a second opinion. They said that this guy, he complains of Achilles problems, but there is nothing wrong with his Achilles. Ultrasound and MRI is normal. So we have promised him a second opinion, but then we will cut him out from the team here. So he came over, and we didn't find anything on the ultrasound, but he could put his finger exactly on the spot where the pain was when he was trying to run in a curve. So we asked him, can we open up? Do you allow us to open up little local and a small incision? And he allowed us to do that. And look what we found. Normal tendon here, but if you look closely on the inside of the Achilles, there was a little ditch, and in that ditch was the plantaris tendon. And when you rotate the foot like they do in the curve, this plantaris tendon flipped out and back. So we asked him if we could cut the plantaris, and he said, yes, please do that. And he became pain-free. So he was not mentally weak. He had a normal tendon, but his pain was coming from the plantaris. And that started lots of research on the plantaris tendon. As you know, it comes from a small muscle up here, lateral, behind the knee, and it slides in between the superficial and deep calf muscles. See here, and then it curves down on the medial side of the Achilles and inserts down here on the calcaneus. But there are many different routes. You know, in the old textbooks we learned that only 60% had a plantaris, but now we know that everyone has it. There was a good cadaver study done by a Dutch group that showed that all individuals had it. I think they had looked at 100 cadavers, but there were 9 different positions in relation to the Achilles. So you can have it invaginated, you can have it far away from the Achilles, and the insertion can be quite varying. So that was also interesting, that the plantaris can be a factor. So by then I got a research student, a fantastic German guy, Christoph Spang. So I provided him with 87 plantaris tendons, and he really went into that and studied that deeply. And what he found was that there is tendinosis also in the plantaris tendon, not only in the Achilles. You can have plantaris, you can have tendinosis. There are lots of nerves in between the plantaris and the Achilles. This is the Achilles, here is the plantaris. In the tissue here in between there are lots of nerves. And there are also nerves inside the majority of the plantaris tendons. So the plantaris tendon in itself can cause pain. We were involved in a project at the Mayo Clinic in America together with Jay Smith, and we could show with him that the movement of the plantaris, this is the Achilles, and here you have the plantaris moving at the side. There are different movement patterns, and here you also have the plantaris moving, sliding along the medial side of the Achilles, and we found 3 different movement planes for the plantaris together with the Achilles. So here we have a little summary of that. So it might be involved in Achilles tendinopathy. The mechanical properties are different. The plantaris is a very stiff and strong tendon, much stiffer and stronger than the Achilles. But it's normally very small, but it can grow and be quite thick. At least half the size of Achilles we have picked out sometimes. And it can cause compression. So there are many possibilities for the plantaris to be involved. And you can also have a completely normal Achilles but a severely tendinopathic plantaris causing lots of problems. Like I showed you on the sprinter, you can also have different types here, like this one. You see, this is a cross view of the Achilles, and here you have a very, very thick and wide plantaris. This was also a sprinter who couldn't push off in the start. When he went into forced plantar flexion, there was sharp pain coming from the plantaris, not from the Achilles, from the plantaris. And then you easily can take it out with minor surgery and local anesthesia. So let's move over to the insertion, and you know the insertion, that's much, much more problematic. It's problematic because we have multiple tissues involved. As you know, you have the subcutaneous bursa at the back of the heel, just under the skin. You have the retrocalcaneal bursa between the bone and the Achilles. You can have loose bone ossicles here in this region or down here. You have the plantaris insertion on the medial side, and you have also the Achilles in itself. So all these different tissues can be involved in combination or alone. But the problem is that we don't know very much about where the pain comes from. There are no studies clarifying the innervation patterns for the insertion. And when you then end up needing to operate these patients, it's very difficult to know what do I need to take out, what tissue should I focus on. So we did also research on patients that they had combined pathology. They had ultrasound shown pathology in all the different tissues. And then we analyzed that to find out in what tissue do we have most nerves. What is the most important tissue to deal with if we operate. And interestingly, we found that most nerves were in this subcutaneous bursa. This bursa here, between the skin and the tendon. That was the by far number 1 tissue. So if we only could take out one tissue, that was the tissue to take out. And that was completely new information. So that was a little bit about the research we have done up in Umeå for many years. And I will talk more about that in the afternoon, how we have used this research to start new treatments for the mid-portion and for the insertion. And as you know, it's a big team approach, this type of research. This is the professor of anatomy, this is my boss at the sports medicine unit, the radiologist, lots of young researchers, and now, of course, I have not mentioned the groups in other countries like England, Mayo Clinic and Australia, so it's a big collaborative effort. So thank you, we talk more in the afternoon.
So thank you for this wonderful talk. Αυτό που είπε τόσο ο κ. Alfredson, αν μπορώ να το συνοψίσουμε, το εξής. Πρώτον, οι φυσιολογικοί τένοντες δεν έχουν αγκίωση και νεύρωση μέσα στην μάζα τους. Οι παθολογικοί τένοντες έχουν παθολογικά αγκία και νεύρα γύρω από τη μάζα τους. Τα νεύρα αυτά είναι υπεύθυνα για τον πόνο. Άρα, πιθανώς να πρέπει να παρέμβουμε πέριξ του τένοντα για να απαλλάξουν τον ασθενή από τον πόνο παρά μέσα. Το αποδεικνύουν αυτό με ανοστοϊστοχημία βιοψίες, κάνουν εγχύσεις τοπικές που μειώνουν τον πόνο, αφαιρούν το αγκιονευρώδη στο γύρω από τον τένοντα και ο τένοντας αναδομείται και η ασθενής είναι καλύτερα, αλλά πιθανότατα πια δεν χρειάζεται να μπούμε μέσα στον τένοντα για να το θεραπεύσουμε. Πρώτο μήνυμα. Δεύτερον, στη μεσότητα του αχιλλείου πάντα πρέπει να σκεφτόμαστε το μακρό περματικό. Ο μακρός περματικός κάνει πρόσκρουση στην εσωτερικά του αχιλλείου στη μεσότητα και πολλές φορές είναι αιτία πόνου. Και κάτι πρέπει να κάνουμε γι' αυτό σε ασθενείς που δεν είναι καλά. Πάντα θα το έχετε. Δε για την κατάφυση του αχιλλείου είναι πολύ σημαντικό να ξέρετε ότι ο κύριος πόνος έρχεται από την επιφανειακό οργόνο θύλακο, είναι το βάθρα, συχνά το επιφανειακό οργόνο θύλακο. Μπορεί να έχει ένα αχιλλείο που έχει 1000 πράγματα, αλλά κύρια αιτία του πόνου είναι η επιφανειακή υποσύνθητα. Άρα πρέπει να το πούμε πάντα κατά νου αυτό και να δούμε τι μπορεί να κάνουμε σε αυτό. Ωραία. Αυτό ήθελα απλώς στα ελληνικά να κάνω μια σύνοψη. Υπάρχουν ερωτήσεις για το basic science σχετικά με τον αχιλλείο, για τον καθηγητή. I think you will get all the questions after your second talk because we are running late. You're okay with that?
Absolutely.
Okay. Thank you.